Our next topic would be spina bifida, and there are three types of spina bifida that we're going to study a little bit about, and that is spina bifida occulta, and that means hidden. In other words, if you look at the baby's back, you don't see any bulging, you don't see any clear sac, anything, but what you may see is either a tuft of hair or a dimple at the side of this, and it's just where the spine did not close entirely to enclose the spinal column and spinal cord. The next one is spina bifida cystica, and there are two types of that. There is the meningocele and the myelomeningocele. With meningoceles, you'll have the protrusion on the back, and contained within this sac, protruding sac, will be the meninges lining it and CSF within it. With a myelomeningocele, you have those two things, the CSF inside the sac, which is lined with the meninges, and then you will also have spinal nerves, and probably the spinal cord is involved in there as well. And the third one would be anencephaly, and that is where the child is born basically without a brain. And I will give you examples of that a little bit later and show you pictures of it. In this slide, I put it in simply for you to get a better feel for when you see the location described in a child with spina bifida. Just realize that the higher the defect, the more neurologic deficits the child will have, as well as movement and sort of be orthopedic problems and neurological deficits of the lower extremities. The lower it is, the less impairment the child will have. And you'll have to blow this up a bit, but on the right-hand side is a chart that literally tells you, based on where they are at T, whatever, versus L, versus all those S's. It will tell you exactly what deficits you would see related to the various areas that the myelomeningocele could be located at. In this slide, I'm showing you simply what some of the children who have spina bifida, some of the problems they may have orthopedically. You see top right would be a club foot as in the middle, and then on the left-hand side, different versions of club feet, but they all have them. On the right-hand side in the middle would be a child who has developmental dysplasia of the hips. And then the two bottom pictures show babies with anencephaly, meaning they have no brain. This is incompatible with life. They do live short amounts of time, a week, maybe 2 weeks, without any interventions on our part. So if they put a G-tube in them or Mickey button, ventilators, that kind of stuff, they can make them live longer. The positive part is that anencephalic babies are perfectly healthy otherwise and make excellent organ donors. And many parents find a great deal of, peace in knowing that their child saved a lot of other children's lives. As far as etiology or why spina bifida occurs, we know there are some genetic components. So if you have a strong family history of that, you're more likely to have a child with spina bifida. We also know if the mother is exposed to some type of viral illness while she is pregnant, especially early in the pregnancy, that can also lead to this. There are certain medications, such as specifically our anticonvulsants, that we know make you more likely to have a baby with spina bifida. More common in Caucasians and more common in girls than boys. And of course, if mom is exposed to x-rays or some type of chemicals while she's pregnant, that can also damage the baby and cause these things to happen. Additionally, if mom was obese pre-pregnancy or has diabetes, that also we feel is proven to be a contributory factor. And then if, hyperthermia during the pregnancy or low vitamin B12 levels will also. But the only one of these we really can make a major impact on is the next to the bottom, which is our lack of folic acid in the diet. We do a lot of education for women on making sure that women of childbearing age will get adequate amounts of folic acid in their diet on a regular basis, because it's not something that once you find out you're pregnant you can start doing. You need to do it prior to conception. As far as diagnostics for a child with spina bifida, they either will be diagnosed prenatally from ultrasounds, or it may occur at birth when the baby is actually born and you see the defect on the back. Prenatally, they're going to do ultrasounds, as I said. They also are going to draw a serum AFP on the mother. All women at around 16 weeks gestation will have a number of test run blood work-wise on them, and this is one of them. If it is elevated, that indicates that the child may have spina bifida, so they're going to do some additional diagnostics on them, maybe an amniotic AFP, something like that, as well as a more detailed ultrasound on them. Now, they can have an elevated AFP and have a perfectly healthy baby because A, maybe their dates are off, or B, maybe there's more than one person living in there. If a mother's having multiples, that would make the AFP elevated as well. And then, of course, prenatally, you would see it by visualizing the defects, or if you see a dimple or a tuft of hair or something on the back, you can do an MRI or a CT to determine if that really is a spina bifida, a lesion. When a baby is born with spina bifida, preoperatively, our number one goal and our responsibility is to keep that defect covered and moist. Hopefully it came to us in the NICU intact. The sac around it had not ruptured, and it is our job to keep it intact till we send that baby to surgery. So we cover it with a non-adherent dressing, sterile gauze works nicely, something like that, and then we make sure it is always moist. We do place the babies on warmer beds to maintain their temperatures for thermal regulation reasons. And they always will be placed on their tummies with the hips flexed somewhat and the legs abducted. This is just helping with it because of the orthopedic anomalies that go along with this. We try to position them in what we call a neutral position. And as I said, they will be probably in a warmer bed. Isolates or work is not a problem with that, but it's just easier to manage the child and get to them for care if they're in a warmer bed. We are doing strict I&Os on these children, monitoring for urinary output, as well as stooling, because with spina bifida, many of these children will have neurogenic bladders, and they will lack bowel control, so they may just ooze meconium and dribble urine. So we're watching very carefully how much they're putting out, and then noting how they are avoiding or stooling. Is it just drip, 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 or do they actually have a forceful, regular void and stream like you would expect a baby to have? We also place skirt diapers on them. The baby on the bottom would have what we would kind of call a skirt diaper. And what it is, basically, it is a diaper we open up and we place over the buttocks below the lesion, or if they've had the repair done, below where the surgical repair was. And it basically keeps the stool and the urine off of the lesion or off the defect or the surgical site. And if we're wanting to know if they voided or stooled, you just simply lift the flap up on the diaper and you look and see. If so, you clean them up and may have to change the skirt diaper if it got stool on it. But we do that as a protective mechanism. Additionally, we do a lot of skin care because if they are not able to move the lower extremities, we want to make sure that we are positioning well. We have enough padding under their legs and knees that they're not going to have skin breakdown. And we do passive range of motion exercises for these babies because they are unable to move their legs After they go to surgery and they come back to us, they will be positioned in a prone position. They will have to stay on their tummy. They cannot lay on their backs. Now, we can turn them to side, but they definitely may not lay on their backs. We're also going to monitor their daily head circumference because the problem with spina bifida is when we close their backs, if we do not put a shunt in them to prevent hydrocephalus or to treat the hydrocephalus, many of these babies will develop it. So the majority of children who have spina bifida and have the lesions closed will also have a shunt put in for just those reasons, so they won't develop hydrocephalus. We're going to do neuro checks on them and neurovascular checks, making sure that once they close the back, that you still have those little feet and toes, that they are warm and have good cap refill in them. The neuro checks, of course, will be the usual, as far as checking pupils and those sorts of things. We continue with our passive range of motion and working on those lower extremities. We'll of course, give them antibiotics, just like with hydrocephalus. We were playing in the brain, we're playing on the back now. So still, the neuro system, we're not going to forget the antibiotics, and they will be getting multiple antibiotics, some pretty strong ones too. We want to make sure we're monitoring this child for any kind of infection, looking for any leakage, drainage, anything that from the actual surgical site itself and on the dressing. And once they come back and they're over with anesthesia and waking up and seem pretty alert, doing well, then we can start them on feedings, whether it's bottle feeding or breastfeeding. We simply bake a donut that will fit around the lesion where it's been repaired on their back, and then you put a blanket over them, wrap them up, and you can hold them. The objective is to not put pressure on the op site. And by putting a little round up like a donut, you stretch it out, roll it like you're rolling up a towel, and then put the two ends together. It makes a donut, similar to what mom sleeps or sits on, rather not sleeps, but sits on after she delivers. And therefore, mom and dad can hold them and love them all they want to, and they don't have to be worried about hurting the back where the surgery was. And I put the top picture in for you to understand that these children are excellent candidates for intrauterine surgery. What they do sometimes with these babies, if they identify it on ultrasound at 16, 18 weeks, what they will do is they will take mom in, open her up, take the uterus out, open it up, and bring the baby out, because now remember, the baby's still attached to mom from umbilical cord. So baby is sleeping because mom is sleeping, anesthesia. And they repair the baby's back and then put the baby back in the uterus, sew it back up, put the uterus back into mommy, and let that baby gestate for a little longer. And they have really excellent results with this. So it's really kind of a cool thing. We've probably all seen this picture where the baby is literally trying to hold the doctor's fingers. I think it's so sweet. And I just put you two more pictures, let you kind of see what it looks like pre-operatively. There was the lesion of the spina bifida on the left. And then afterwards, you'll have the child will come back with a very large dressing covering their back. Maybe not quite that low, because you're also covering the buttocks, and we definitely need to not get that dressing dirty. So it will be a little bit shorter. And don't ask me what that tail-looking tube thing is. I'm sure it's some type of drain from the surgery. But I've looked high and low to find one with just the dressing on it, and I can't find one. So this gives you the idea of what a dressing would look like on that baby's back. Once they're recovered, we are ready to basically send them home. And part of that is understanding that this child, though they may be limited in movement, because many of these kids will not be able to walk. They will have to be in a wheelchair, or in those little girl shows, long leg crutches and those sorts of things with the walker. But we try to not limit them and make them a handicapped child any more than we absolutely have to. We provide the services that they need for them, OT, PT, those sorts of things. Wheelchairs, we try to keep them involved in sports and activities like any other child, and to make them understand that they're just different, a little bit different. They get around differently, that sort of thing. We, of course, will talk to the parents while they're babies about the fact that if they do have myelomeningocele, that they're not going to gain back movement of the lower extremities. If they can't move their legs as a neonate, they're not going to start moving them when they're a toddler or a preschooler. So we're talking to them early on, reinforcing that to them. It doesn't impact them, see, as a baby, because you carry babies around with you. But if a child begins to get old enough to be crawling and trying to toddle around and walk, then it's kind of in the parent's face, so to speak. They realize, like, she really will never walk, will she? And we just simply reinforce them. No, she won't, but she will be in a wheelchair, or she will have long leg braces, whatever is appropriate for that specific child. And then we simply reinforce that for the parents, to try to treat them as normal as they possibly can. Long-term complications we do see with these kids are things such as constipation or bowel incontinence. As they become teenagers, many of these children will go through a procedure wherein they may have a stoma that they can basically do an enema through in the mornings. In other words, like a washout with them before they go to school, so that they have no risk of soiling themselves at school. It's kind of like they just do a cleansing before they go to school, and they have to get a special stoma put in for that. But many teenagers with spina bifida will do just that because they say it's too embarrassing. Secondly is, of course, if they have bowel and bladder incontinence, then they're going to be required to be cathed throughout their life. So as infants, parents have to know how to do it. And as the children get older, they are taught how to cath themselves. So we try to make these children as independent as they possibly can be without making them handicapped, as I say on here. And with this, just as I said, read and enjoy. We were talking about some really difficult subjects, so enjoy.